runny noses. Next, On Call with the Prairie Doc.
Good evening, and welcome to On Call with Prairie Doc. I'm Dr. Tom Luzier of Aberdeen Asthma and Allergy. Dr. Holm is on assignment and will be back next week. Most of us tend to take breathing for granted. We do it 12 to 20 times each minute if we're a healthy adult. But the moment something interrupts that process, either lower or upper airway, we notice it. The most common interruption is some form of nasal congestion or obstruction, and it may be caused by a variety of sources. Tonight's program will focus on nasal congestion in its many forms. Okay, first let's take a look at this week's Prairie Doc quiz question. It's a multiple choice tonight. The most common allergy is from cat dander, dust mite bug dust, tree pollen, grasses pollen, or weed pollen. Viewers who call in with the correct answer will be entered into a drawing to win a signed copy of A Picture of Health. This book was written by Dr. Holm and is accompanied by photographs by Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only got 10 minutes to get your answer in. We answer your medical questions about how to deal with nasal congestion as they are called in or sent to us. You can use Facebook or email, or call your questions in to 1-888-376-6225, or send us an email. Join us tonight, Dr. Bob Smith, Allergy and Asthma Clinic of Sioux Falls, and Jered Mancell. He's at Prairie Lakes Healthcare System in Watertown, South Dakota. Bob, tell us a little bit about your background.
I grew up in Iowa City, Iowa, and attended University of Iowa. Did my training, my allergy training at University of Iowa, and to be an allergist, you usually have to do not only your 4 years of medical school, but 3 years of either pediatrics or internal medicine, and then you do another 2 to 3 years of subspecialty training after that. And then you take a test and you become a board-certified allergist. So we primarily are focused on what's called type 1 hypersensitivity, which should be things like allergic rhinitis, allergic asthma, but some allergic skin disease things as well.
So how did South Dakota get so lucky to get an Iowa guy?
Well, I just followed my wife up here. So, and then I ended up staying. So I thought I'd only be here for 4 years, but here I am, 28 years later, still here.
He is a Hawkeyes fan.
That's true.
I will attest to that. And also with us is Jered Mancell. And Jered, tell us a little bit about you.
Thank you. I grew up in southern Minnesota. I attended University of St. Thomas for my undergraduate, medical school in Missouri, and then made the trip to Michigan for the 3rd and 4th year of medical school and my 5-year residency program in otolaryngology and facial plastic surgery.
And how did we get so lucky to get you in South Dakota? My
wife's family's from the Fargo-Moorhead area. My family's from southern Minnesota, and it worked out just perfect.
So South Dakota's in the middle.
Exactly.
Exactly. So we're going to talk a little bit about nasal congestion. And, you know, from my perspective as an allergist, I depend heavily on my ENT colleagues to keep the upper airway open. Tell me a little bit about the things that you see that the audience might be interested in regards to nasal obstruction and congestion.
Okay. So when I evaluate a patient for nasal obstruction, the first differentiator I'm looking for is it a static or always there problem, or is it a fluctuating problem?
So is this like the people who get up in the morning and I'm stuffy then, and then they feel like they're okay?
That could be the fluctuating side of things, but the static things are problems with congestion that just won't go away. They're there most of the time, if not all of the time. Those are anatomic problems that typically need some sort of correction, either medical and or surgical.
How do you see up in that airway of ours?
So you do need special instruments. For the most part, just looking up there with an otoscope is going to get you into the first 2 centimeters of the nose. We do have speculums that open the nasal pass or the nostrils, and then bright headlights to try to see up there. That gets you about halfway back. The rest of the way we do use endoscopes, both flexible and rigid, to be able to navigate our way back through to the nose all the way into the back of the nose.
So you stick something into the nose all the way back to the throat?
Absolutely.
So tell me a little bit about what that looks like and what that does.
So we We typically anesthetize the patient's nose with some numbing medication.
Oh, that's
They
nice.
appreciate that. Yeah. It also decongests the nose to make the cameras fit, but the cameras are no bigger than the cord on your mouse on your computer. The flexible cameras have come a long way, and their picture quality is just as good as their ridges now, so I tend to use those quite a bit. It helps me navigate around physical obstructions in the nose. But essentially, we start in the front of the nose and work our way to the back on one side into what we call the nasal pharynx, and look at a few of the key structures along the way that play a role in nasal congestion, allergy, and sinus, and then do the same on the other side.
Awesome. That's very good. Now, Bob, you also evaluate the upper airway. Is there a difference in what you're doing compared to what Dr. Mancell does?
Again, usually our patients present what seems like cold-like symptoms, right? But it's a cold that doesn't go away. And for the pollen seasons, the presentation is a little bit different. They usually come with runny, itchy, drippy, sneezing, and then eventually become congested and post-nasal discharge, like a cold that doesn't go away. But this time of year, it's usually things inside the house. They primarily are coming in for not runny, itchy, sneezy, but what seems like a cold that just doesn't go away. And for evaluation, usually they can come in and you can test for this sort of thing. You could either do skin testing, which is considered the gold standard, or you can do blood testing, which is almost as good, and see if you actually make antibodies against things such as cat dander, house dust mites, or in the seasonal, the pollens and the moles and so on.
So, you know, I get asked a lot about decongestants, and that is an effective way of relieving some of this nasal obstruction. Jered, what do you think about?
Well, in my opinion, there's two major classes, the topical sprays and the oral decongestants. They're both very effective. The downside is they have a lot of side effects. I tend to not prescribe or recommend any of the oral decongestants. They can have side effects with the heart rate, things like that, blood pressure. The topicals, I use in my office every day. It's an excellent nasal decongestant for scoping patients, for stopping nosebleeds, things like that. But the downside is if you continue to use it beyond 3 to 5 days, you end up with a rebound congestion, and these patients end up more congested than they were to begin with. So I do stress that point. I rarely recommend the sprays unless somebody needs to just get over a real bad part of things, but I definitely make sure they know that they cannot continue that medication.
I've got some questions that have come up already here, so let's take a look at it. This first question from the audience: my grandson needs his turbinate cut. Well, what is a turbinate, as we're going through this? And he needs it cut down, but we still have the dog allergy. Will he be a lot better off after the surgery? So tell me a little bit about what a turbinate is, and we'll kind of go from there. Inside
the nasal cavities, on the outside walls within the nose, there's 3 bony structures, if you picture them kind of like shelves. And they're covered with the same lining inside the nose, what we call the mucosa. These turbinates, there's a good image. These turbinates, especially this inferior turbinate right here, has high density of blood vessels called venous sinusoids that have the capacity to swell and shrink when more blood is entering or leaving the venous sinusoids, which make them kind of the prominent one for congestion. Pretty much any kind of inflammatory agent can cause those to swell up. But it's one of the things that we can evaluate in the office. We see these huge turbinates, especially the inferior turbinates, way up front in the nose. And the more obstruction we have in the front of the nose, the more symptomatic people are. So we can surgically reduce those. We can also reduce them with medications.
So is this mostly like soft tissue, or is there like a bone in there?
It's both. There's bone underneath and soft tissue, and that's kind of one of the things that we evaluate in the office. We do spray a decongestant spray which shrinks those blood vessels. We evaluate it after that, and we also ask the patient how much better did their breathing get. Sometimes the bones are just too close to the middle, which obstructs the nose. And sometimes it's mainly soft tissue. After you spray them, it really shrinks down, and they say, man, I would love to live like this. When they really respond to the decongestant sprays, that tells us that it's a soft tissue problem, and that can be reduced with either medications and or surgery.
So Bob, real quickly, if they have a dog allergy and don't get rid of the dog, and he cuts the turbinate down, Do you think that's going to be able to keep
Not really.
his obstruction?
You would want to approach it from the dog allergy side first, certainly. And my understanding too is that turbinectomies are really last resort options, especially for children. And that it can interfere with the normal functioning of the nose later on, and interfere with the normal nasal cycle function of cleaning the nose or refreshing the lining and so on. So usually turbinectomies are left as a last resort.
So we're thinking, take care of the dang dog
allergy. I'm not sure what
allergy.
Jered would say, but usually for children, aren't they absolutely reluctant to do surgery like that sort of thing, where they'd be cutting things out? I mean, for adults, they might be more likely to do it.
For sure. For kids, you know, there is a radio frequency ablation that they can use, which is much less invasive. It's still invasive, and it can still have some side effects. I reserve that for, like Dr. Smith said, a last minute or a last resort.
What kind of side effect do you get from?
You get what we call atrophic rhinitis or empty nose syndrome. The nose needs turbulent airflow to sense airflow moving through that. And they used to remove the turbinates, and you'd think, wow, a huge nasal passageway all the way back, things should be great, but people still complained of obstruction. They call it an empty nose syndrome.
Wow.
They can actually get dry nose and things like that too if you're over-aggressive with turbinate resection.
Awesome. Okay, very good. Let's talk a little bit about chronic congestion. Just sounds like a bad deal, doesn't it? And it is. From just making your daily life uncomfortable to interfering with work and family. Fortunately, there are a variety of treatments to aid in living with this problem.
When I turned 19, I was referred to an ear, nose, and throat specialist, Dr. Genesys, and he recommended I have my first sinus surgeries. So in 2003, I had my first sinus surgery. They cleaned out my sinuses. They shaved my cheekbones, kind of tried to enlarge the openings to help with drainage. And after that surgery, I couldn't believe how much better I felt. I mean, I had tons of energy. It was almost like I didn't remember what it was like to feel good. And so the thing about chronic sinusitis is it's kind of insidious that way. It creeps up on you. You don't realize how fatigued you are. You think having headaches every day is normal, when really you're very sick. And so after that first sinus surgery, I felt great, you know, high energy, plus I was 19. I mean, it was an easy recovery. Probably since 2010, I was kind of back to that same cycle of having a sinus infection every 3 to 4 months. Maybe I'd get a Z-Pack, or maybe I'd get 2 Z-Packs, or we'd try C-Chlor, or we'd try whatever else was new, you know. I remember just sitting in a doctor's office and running down the list of antibiotics we tried, and I'd be like, nope, that doesn't work, nope, that doesn't work, you know. And I just wasn't responding to any antibiotics at all. So finally, last February, I just went to an on-call doctor, and he said, look, I'm going to put you on a 3-week taper of prednisone, but you got to have a sinus surgery, you know, call your ENT. So my ENT had moved to Sanford at that point, and I scheduled an appointment with him, but at that appointment I was actually 5 weeks pregnant. So there was nothing to be done but, you know, just be diligent with the neti pot and do my nasal spray and just take a lot of over-the-counter headache medicine. And then I had my child in October 15th, and 2 weeks after that I had my second sinus surgery. So this procedure was slightly different than the first one. They used a balloon and inserted the balloon into my sinus, cleaned it, or inflated the balloon, cleaned out all the congestion, put some antibiotic in there, and this is supposed to last longer, have less chance of recurrence. It's just a newer procedure. I will say, because I was 2 weeks postpartum, the recovery was much longer. It took me about 3 weeks to recover. Like, I don't recommend having a newborn and then having a surgery 2 weeks afterwards. Now I'm back at work 6 weeks later. My energy is 100%. I'm so productive at work. I feel great. Even though I'm at home nursing an infant, I actually have more energy than I did before I had the infant, just because I'm feeling so much better from the surgery. Since the procedure has been done, I can blow my nose and actually like blow congestion out, which is so refreshing, because the only way congestion was draining was down my throat before. And, you know, of course then, You're dealing with nausea all the time, in addition to headaches, neck pain, jaw pain, teeth pain. You know, every nerve in your face becomes so inflamed. There's a lot of pain.
Well, we're back with our two guests, Jered Mancell, Dr. Bob Smith, and it's also Dr. Mancell. And as they were giving us this information about sinus surgeries, this young lady had two of them, they mentioned this thing called balloon sinuplasty. And since I don't do these procedures, tell me a little bit briefly about the balloon compared to the older procedure, or really not older, the FESS procedure.
So, correct. The traditional FESS was, I guess, what most people would associate with a Roto-Rooter surgery. It's removing bone and tissue to open the natural passageways of the sinus. As you can imagine, the nose is very vascular. Removing mucosa and bone does lead to some bleeding. Anytime there's exposed edges, you can get to some adhesions between the important areas in the nose. So essentially, out in the cheek sinus, there's one key area right in there that we call the osteomeatal complex, which is kind of the keystone area. The sinuses need air ventilating them and room to drain for them to function correctly, and that's a common site of obstruction. So the traditional FESS was removing bone and tissue to open these sinuses, depending on which sinuses were infected. During my training, this thing called balloon sinuplasty kind of came about, developed by a cardiac interventional cardiologist, I believe, for the heart. So it's the same principles they use for angioplasty and things, but it's novel in the sense that the goal is to open the same anatomical structures with minimal damage, creating a radial dilation within the osteums or the openings of the sinuses.
They just open this. They just compress the soft tissue. Does it break any bone?
It does break the bones. The bones underneath this tissue are very thin anyway, so that's what we want. Is we want an outfracturing of the bone in a radial pattern, and really minimal tearing of the mucosa.
So now this lady said that it took her a little longer to recover from the balloon than the FESS, and at least I've kind of read that the FESS is harder to recover from than the balloon. Was that unusual for that?
I would say that's not the common response. I would say most often, depending on the level of the surgery that she had done and what was addressed, the recovery from balloon sinuplasty is much shorter. Oftentimes people go back to work the next day. It is a procedure that we're able to do in the office.
We're coming off a pregnancy, that might have played a role?
It could have, for sure, yeah. I mean, we don't know the whole story, I guess, but
now,
typically...
do they do this thing in the office?
They are doing it in the office. I'm currently not. We have our surgery center right upstairs, which is very convenient.
Well, it's kind of like being in your office.
And I haven't had any patients beg me to do it while they're awake. But yes, we did it in training that way. More and more people are doing it, and it's a nice option for the right patient.
Okay, well, we've got several questions that come up, and one of them is how do you stop congestion at night when it isn't caused by a cold? This is challenging. That's why I'm giving it to you.
All right.
Or allergies.
Well, first of all, what's normal at night is that if you sleep on your side, whatever side is down is going to plug up. That's just how the nose works. If you flip over, it'll open up, but now the new side that's down will plug up. So you can't really fix that. If you sleep on your back, it's kind of like during the daytime, it's the nasal cycle. It'll just go back and forth every 2 to 4 hours. So if it's not normal to have both sides stuffy. So if both sides are stuffy, then for non-allergic things, there's something called irritants. And irritants are something given in a big dose would bother everyone. So obviously cigarette smoke and perfume, sticky flowers, and so on. But you can also have issues this time here with it being too dry, and then those finds that uncomfortable and may get stuffy just because the air is too dry. But you know, it's a little tricky. If the allergic people run a humidifier, then of course that allows the mites to grow and the molds to grow and so on. But for non-allergic people, right, if it's too dry, you know, adding humidity to the air, things like that can help. Sometimes if they have the fan going, it can kick up dust in the room, and that can be a physical irritant as well as an allergen.
Yeah. Do you think we take a lot of stuff that we get exposed to during the day to bed with us at night in regards to the nose? In other words, if I work, I'm a welder, and I come home? Is that those kinds of jobs?
I certainly think that's possible. I wouldn't think it'd be a very common thing. I'm sure the welders probably take a shower or bath, or probably don't wear their work clothes to bed. But in theory, maybe in their hair, something like that. You know, the other things that can cause like non-allergic stuffiness, the folks who wear CPAP at night if it's not properly humidified and so on. And then many patients, as they get older, they start taking medications like hypertensive meds can give you nasal congestion. So we have some people come in who say, you know, the last 4 years I've had more stuffiness, congestion. And we said, well, when did you start your blood pressure pills? Well, blood pressure pills, the better they work, oftentimes give you more congestion. Or for younger women, birth control pills can give you nasal congestion and things like that as well. So medications can. And as Jered mentioned, it's very, you know, very impressive how well the topical decongestants work. And many people try to take that at night because it really blasts things open. But if you do that every night, then eventually now you have to start doing it during the day too, and it just gets worse and worse. So sometimes just using the over-the-counter topical decongestants like Afrin or Duration, oxymetazoline, and that will cause nasal congestion. And then it, you know, initially it lasts all night when you use the nasal spray, but eventually as it lasts shorter and shorter, you're waking up in the middle of the night stuffy too.
What about position? I mean, I hear about people sleeping in recliners and things like that.
Well, in terms of causing the nasal congestion or because of the nasal congestion?
Make it better.
Oh, well, it might. I mean, obviously, when you lie down at night, I mean, whatever side is down is going to completely close. So whatever side normally is open, if you have congestion on both sides, well, that's going to be really bad when you're sleeping at night if both sides are stuffy. So sometimes it's better to sit up and then you get at least some opening and so on. But that's not the normal way to sleep, right? It's going to be uncomfortable. And so if you interfere with somebody's normal sleep patterns, then the next day they're going to be tired and not be able to function as well and so on.
So we've got medicines to look at, we've got position to look at,
irritants
to look at, and these are all things that aren't colds and aren't allergies. Are there any medications like this salt water and that kind of thing that work that don't give you this bad side effect?
Well, the topical decongestants have rebound, but the oral decongestants like pseudoephedrine and stuff, they don't have rebound, right? Their dilemma, of course, is that they're not very strong if you have severe symptoms, and the other is that if you have underlying conditions like high blood pressure, they do the opposite of the high blood pressure meds, but most patients will tolerate them. Our big issue with decongestants at night is they can cause insomnia for about 15 people out of 100. So for 85 out of 100, they can tolerate it, take it at bedtime, maybe sleep better and so on, but for some it's an issue, they just can't use them at night.
Okay.
But
well, we actually have a picture here for our audience to look at, and it gives us an idea of how these decongestant sprays work and that kind of thing. So we're going to put up just a graphic of somebody putting a spray in their nose and talk about decongesting. So Jered, explain a little what's happening here.
So what they're doing is introducing the actuator into the nostril on the right side. The septum, which is the midline divider, is no longer showing there. That's the outside wall of the inside of the nose on the right side. What you're looking at there, the turbinates I tried to describe earlier. Again, this would be the inferior turbinate, the middle turbinate, and the superior turbinate. This inferior turbinate, again, like I said, has those venous sinusoids that have the most contractility and expansion properties. That's where I tell my patients to direct their nasal sprays.
I noticed that they tilted the head down. Do you think that's important?
I do. Most of the actuators are gravity dependent, so I tell patients how to get the relationship straight back, slightly out, and then we tell them to lean forward so they don't misfire with the actuator. I think that's important too.
Very good. Thank you very much. We have a question here, and this one I'm going to direct to Jered, because I think you'll just love this question as I find it. I've been diagnosed that I'm losing spinal fluid through my nose. What's the procedure that addresses this? How would I even find out I got spinal fluid coming through my nose?
So spinal fluid is called cerebral spinal fluid, CSF. It surrounds the brain spinal cord, and the only divider between the brain and the nose is a thin bone. So oftentimes with traumas, with surgeries, iatrogenic injuries, and sometimes spontaneously we can lose that spinal fluid if there's a gap between what holds the brain and the nose. So it also can happen in the ears as well. We call that a CSF leak.
Where on this picture do we have that little bone?
So the brain is here, the skull base is here, And it's a very thin bone there, and then all this is surrounded with CSF fluid. If there's a defect there, for any of the three reasons I mentioned before, we can get CSF leaking into the nose.
CSF is cerebral spinal fluid.
And oftentimes people don't know that's what it is because most people have some sort of clear rhinorrhea or clear watery drainage from the nose at times anyway. There are special tests we can do if we can collect some of this. So the procedure to fix that is oftentimes a skull base surgery, oftentimes done by people with extensive training in the skull base and rhinology. And
so
to
you
go in
actually
there
have
and
a
patch.
specialist of ENT
Correct.
or neurosurgery that goes in there and repairs whatever kind of defect there happens to be there, unless it's like a tumor or something that's
Correct. Yeah,
coming
oftentimes after skull-base tumor resections, that's one of the side effects, the complications of it. Sometimes it's expected. You know,
So
usually
when I was in residency, they told us that it would help to take the sticks that you use for diabetics' urine to see if it's got sugar in it. Does that really work?
You know, I think the most sensitive test is called a beta-2 transferrin. That's, but yeah,
That's
you're right.
something that's only found in spinal fluid?
I don't know if it's only found there, but it should not be found in the nasal secretions. The same with the glucose. So we do test for that, and then. You know, before surgery, oftentimes what they'll try to do is just relieve the pressure, especially if it's a spontaneous leak or something like
So
that.
what if I don't fix that?
Well, you could actually get some serious infections called meningitis and things where the bacteria from the nose travel retrograde or back up through that defect into the brain.
I think you probably should get that fixed. I agree. Okay. All right. Well, we've got an 82-year-old man, and he used to get sinuses flushed when he was younger. Talk to me a little bit, Bob, about nasal irrigation from a medical point of view, and then you're going to talk to me a little bit about what it is from a surgical point of view.
Because it's really not sinus flushing, it's nasal flushing, right? And you know, for example, neti pots have been around for 1,000 years, came out of India and so on, so it's nothing new, and it apparently doesn't seem to matter whether it's, you know, salt water from the Caspian Sea or the Dead Sea or something, that's the saline itself, but they do have what are called isotonic, hypertonic preparations. Most are, isotonic means it's supposed to be like your own salinity of your body and so on, and hypertonic is kind of meant for head colds, but it's something you can use that will, for example, help for allergies. It washes allergens off the nasal mucosa. So even the placebo group, in the, you know, compared to treatments, gets, well, maybe a 25% or so, 30% better.
Do you think this actually helps reduce bacteria, or are we just improving ciliatal function?
There's some debate whether using it on a regular basis actually might interfere with the normal protective function of the nose too. So I guess there was a study suggesting they might actually get more infections, but you know, it's not, you know, it's not, I think, meant to prevent you from getting all infections or anything like that.
You're right.
Yes.
It is snot.
It's not, huh?
Yes, exactly.
So, but it certainly won't hurt you to do it, and it's certainly on an as-needed basis and so on. It's also nice this time of year for dry noses, which is what we have with furnace on to furnace off.
Now, when I see my patients come back after surgery, many of them are doing a little light irrigation after surgery, getting stuff out of their nose. Is that something typically that you do post-surgically?
I typically do, unless there's some sort of implant or packing in there that I don't want.
Implant is some foreign body that you put in there?
Yeah, most of it, I think saline is extremely healthy for the nose. I think if there was any blood or drainage or anything coming from the sinuses after they were opened, I think washing that away as soon as possible leads to recovery and back to sinus health as soon as possible.
So, question to both of you. You think that saltwater irrigation done properly reduces the number of times that you might be in the doctor's office?
I personally do. I'm a huge fan of saltwater irrigations. I have a lot of patients on it.
I don't think there's any evidence for that. It's mostly testimonial. Works for me type of study.
Okay, very good. We're going to have some other questions here. Do you have anything else about nasal congestion at night and relieving that? Any other ideas that outside? Because I think decongestant does tend to keep people awake.
I think the intranasal steroid sprays can help with swelling of the turbinates. I think that would be a good first line. I would also put them on intranasal saline irrigations.
The nasal steroid sprays tend to work better if you actually have allergic rhinitis, right? They don't tend to work as well for non-allergic rhinitis. There is a nasal spray for non-allergic rhinitis called azolastine, which is actually an antihistamine, and it doesn't really care whether you're allergic or not, and it won't interfere with your sleep or your blood pressure meds and so on. And the big negative is it tastes very sour.
Okay, very good. Well, we have something coming along here. It may not be David Letterman's top 10, but it's Dr. Bubach's top 10 allergy myths. So Dr. Pip Bubach will give us an idea.
Idea of allergy myths, they're real common. Biggest thing is about allergy testing. Allergy testing people feel is dangerous and inaccurate and shouldn't be performed on young kids. Well, in reality, allergy testing can be performed at any age. It's accurate, and at different ages there are certain things that we're allergic to, and there are a lot of other reasons for people to be sick other than just the allergies. Now, the second thing would be that food allergies cause nasal allergy. That's a myth. You might have some nasal congestion while the food causes anaphylaxis, but it's the things we breathe in through our nose that gives us the nasal congestion, so pollens and molds and pets and dust mites. Number 3, intentionally exposing one to pets will cure your allergy. Well, by natural exposure, that's not the right dose, and instead we have allergy shots that can be quite helpful at decreasing the symptoms. Number 4, if you have allergies, you are better off living in a desert or dry climate. Well, actually, in deserts and dry climates, there are still molds, there are still pets. You can still have dust mites, and so just moving to the desert won't fix things, and if you're not allergic to what's in the desert, within about 2 years you'll have allergies to that also. Allergy myth number 5, building dust causes allergic rhinitis. Actually, the dust particles that people have the allergies to are the cat or dog dander, the dust mites, the pollens and mold spores, and it's not the dirt and type of things. Myth number 6, people with sinus and ear problems should avoid milk. Well, there is some thickening of secretions from milk in some people, but milk allergy won't cause the sinus or ear problems unless you have anaphylaxis from it. Number 7, indoor houseplants and flowers cause allergic rhinitis. Actually, you have to get really close to an indoor flower or plant with the pollen to have allergies. It's actually more the dog, the cat, and the dust mite inside that are causing the problems. Myth number 8, antihistamines will lose their effect if taken continuously and will be ineffective if you have a severe allergic reaction. Well, in reality, modern antihistamines don't cause the tolerance issues that were thought with the first generation. And the other thing is that antihistamines don't block anaphylactic reactions anyway. So if you're going to have anaphylaxis, we want to have epinephrine. Number 9, children will outgrow their allergies. That's unfortunately more of a myth because only 25% of kids outgrow their allergies, and we always hope that our kids are in that 1 out of 4. Myth number 10, short-haired dogs do not cause allergies. Well, unfortunately, all dogs have dander, allergic particles. Actually, even within the same litter of pups, you'll have up to 8-fold differences in how much of the allergy particles come off of a dog. I hope that some of these myths can be busted and people just get better with their allergies with proper treatment.
All right, we have a question here from a 76-year-old woman from Brookings. Why is it when people have a stuffy nose and they've got a cough and they've got watery eyes that doctors typically suggest that it's just an allergy?
Well, you can go actually all the way through medical school and the training afterwards and never learn anything about allergy. It's actually considered an elective, so if you can take it as a medical student, but you have to sign up to take it. You can take it as a resident after medical school, but it's not a required thing that you have to learn during medical school. So there's lots of myths, you know, like Mark was talking about, that actually are not really true. So it's not uncommon. So we get many patients who come to see us just because they have been told that it's an allergies, but they either don't believe it or certainly they want to investigate it. And so if you are told that, it's certainly easy enough to test for it.
Does age make a difference with allergy, do you think?
Most allergies present, before the age of 20, most definitely before the age of 35. On occasion, you can get somebody presenting later in life, but what usually happens is that, if you just test everyone, 2 out of 10 are allergic, but only half of them end up going to see a provider, a doctor. So usually in that half that don't go to see the doctor, if they change something later in life, like the kids leave and the mom replaces the kid with a cat and dad's allergic to the cat, then all of a sudden the symptoms would come. So we always want to know for later in life, what's different? Did you change your house? Did you add something to the house? So it is possible to get allergic symptoms later in life, but it's usually those patients going from mild to more severe symptoms because they've changed something.
Do you see a lot of difference in age in regards to this kind of phenomenon of chronic rhinitis?
Yes. I guess one of the things that I think of when I hear these type of symptoms in a patient of that age is something we call vasomotor rhinitis. And it's essentially a diagnosis of exclusion after allergies have been ruled out and everything. It's not the same mechanism, but it's a lot of the same symptoms. And she's asking why do they always write this off as allergy? Well, those are all the buzzwords we're taught for allergy, you know. And like you said, there's not a whole lot of teaching in allergy in med school, and that's what it sounds like. But in order to get to the vasomotor rhinitis, that typically presents later in life. A lot of the same symptoms: congestion, copious rhinorrhea, watery, runny nose, and eyes.
Is there anything that you guys think works pretty decently for that?
I've had some.
Well, their favorite medicine is that azolastine that is fairly fast, works with other minutes. It's actually an antihistamine that really doesn't care whether you're allergic or not. They also like the Sudafedrin because, you know, Sudafedrin doesn't care if you're allergic or not, so they have the stuffy, the congestion, the postnasal drip will help for that, as long as they don't have issues with insomnia or with hypertension, right?
I'm an older guy, and you have to be careful with the decongestant because you may not pee.
That's true.
That's not good.
Can have anticholinergic side effects like that. So
that's not a good thing.
Yeah, not a good thing. But you know,
Do they have
that is the
something you
favorite.
can put in your nose?
Well, and the nasal steroids don't work as well for them as they do for the allergic people. Maybe a third better instead of 70% better. And you have to do those all the time, so they're not the favorite medicine for vasomotor rhinitis.
One of the theories behind vasomotor rhinitis is excessive parasympathetic tone to the nose, which does cause watery secretions.
Wow, that was big. Parasympathetic.
One of the nervous systems, there's a balance between the sympathetic and parasympathetic, and if you're getting too much parasympathetic,
is that something that happens with age?
It can, yeah, especially in the nose. There are definitely physiological changes that take place in the nose, and there is a spray out there called Atrovent or ipratropium bromide that's supposed to help with that.
Have you guys had much success with ipratropium?
It works very well for runny nose, but it doesn't do anything for stuffy, itchy, sneezy. It's just for rhinorrhea, the
This
watery.
is the person that just has water running out of their nose.
Which is not unusual. I mean, we
periodically.
see patients who get into their 70s or whatever, the wiring gets mixed up in their nose, and now they just have this, I cannot stop it, runny nose, and they have to carry Kleenex everywhere they go. So very nice nasal spray. It takes about 45 minutes to work, and the tricky part is your nose is runny, so you have to keep it up there for a while.
Is that the same thing we see when I go out and shovel and my nose is running the entire time?
Could be.
It's just most people have a stop mechanism. So there's something called skier's nose, where even younger people, the cold air rhinorrhea, they can't stop it, so they have to carry Kleenex when they go out. And so this, yeah, is a very effective medicine for like skier's
So
nose.
the cold air does something to the parasympathetic sensing? Is that
one of the
kind
theories.
of what? Since
Something
you use
like
that
that.
big word parasympathetic, I want to use it more often. Yeah, exactly. Is that rhinitis that I get when I eat, like when I go to the Mexican restaurant and have spicy food, is that the same thing as my cold, runny nose? Is it my parasympathetic system getting...
Reflex thing, right?
Right, so I mean, the spicy food could be one thing, but there is another type of rhinitis called gustatory rhinitis that can just occur anytime somebody eats. And
Gustatory.
Gustatory means eating. So,
eating, okay.
While you eat, your nose starts to run, and I tend to see that more in as we age and mature. And the same sort of thing. I'll try the ipratropiums. And,
so would you take that
them.
before you go to the Mexican restaurant?
Yeah, I mean, I guess.
Or do you put it in your purse or your pocket and use it?
Yeah, like Dr. Smith said, 45-minute onset. You do have to plan ahead for those sort of things. It's not something you're going to take during the meal and have it stop things. But
so now I've noticed.
Tell the patients that might work for the 3-alarm chili. How high does it go? 6-alarm chili, it may not work.
Only
for
in
it,
Iowa.
Yeah. So well,
or
Texas.
barbecue or anything like that kind of thing. So what happens with horseradish? Is that the same mechanism as the...
I'd call that a noxious stimuli.
Oh, okay.
It's a pain receptor.
That is painful. That's very good. So now if you go to the Mexican restaurant and they happen to be serving alcohol and you have this hot thing, do you get a stuffy and runny nose from that?
Oh, yeah, I could balance it off. I haven't thought about that.
Okay.
Yeah.
Okay, very good. All right. So we have a 53-year-old woman who had a staph infection in the nose, impetigo, and they're asking about how that occurs. So is staph something that we see in the nose a lot?
It's a really common skin flora, meaning it grows naturally on the skin in a number of people. They've also cultured in a fair amount of community people that's in high prevalence in healthcare workers and things like that. Even the MRSA type, the methicillin-resistant form.
Now that's the bad staph that you...
Bad in terms of less antibiotics kill it. Okay. It's not necessarily any more virulent.
That's what we're trying to get, not be on much antibiotic to get rid of the...
So with this growing in the nose, all it takes is a small crack in the skin, people plucking nose hairs, things like that. A cold where you're constantly rubbing the nose, something to break the skin, and that staph can start growing underneath.
So like when you use your Kleenex over and over again, gives you a break, and then you have that. Is there some, besides oral antibiotic, is there anything we can do to make that better or lower that?
Topical ointments, and I guess there's anti-staph ointments that also treat for MRSA. So those are my favorite to use. So.
Okay. Is there some way we should be blowing our nose so that doesn't happen, or not use perfume stuff, or don't use Bounty towels on your nose? Or go back to handkerchiefs and no.
That's
okay.
I guess just don't be over aggressive with the rubbing, and you know, the skin gets, when our noses get red with a cold, and we're constantly, you can tell somebody's been blowing their nose all day long.
Do you see in the wintertime a lot more bloody nose? I mean, is that really true that we have?
Because the air's drier in the Midwest, it's an issue.
Absolutely. This is nosebleed season.
And it comes up with the nasal sprays, because your nasal sprays possibly can cause nasal irritation, right? So it's more convincing if they're getting the bloody noses in the summer that it's the nasal sprays.
So is that why you said to aim to the outside and not get stuff on the
Absolutely. The septum, the midline divider between the right and the left side, is full of blood vessels.
Well, now I hear about people putting Vaseline in their nose. Is that like a good idea?
I don't like Vaseline. I do like antibiotic ointments purely for the fact that the bacteria shouldn't be able to grow as well on it. It's a good moisturizer. You can't put lotion in there, and the saline doesn't stay long enough. So I think it's one of the better alternatives.
I hear that some people put a thing called mupirocin or Bactroban. Is that a
That's my favorite, again, for the impetigo as well, and the main reason it's water-soluble as opposed to petroleum-based. So.
Okay. Wouldn't sound good to put petroleum-based stuff in your nose and to be on oxygen.
Go to Florida for 2 weeks and
that's got more moisture.
Humidity. Yeah.
Gotcha.
That would be a better
so, okay,
solution.
would you write me a prescription for a trip to Florida? Thank you.
I'm sure Blue Cross would pay for that.
I know they would. So a 55-year-old woman from Gettysburg, and she asked if ENTs work with sleep apnea. And we just had a recent discussion about ENT and neurology and pulmonology all have, because it obstructs and part of it has a neurologic part. So do you do much sleep apnea investigation?
I don't do the diagnostics. You need special certification for that, and it's essentially like a fellowship again now. You can't be just weekend training in it. So I send my patients out for the testing. Once we get the results, you know, I do order the CPAP machines and things like that for them, and then there's a handful of procedures that we can do, you know, if we are able to localize the obstructive area.
So now I've had patients come to me and they have their palate, that's the part of their, see if we can find it here. I have no palate there. So we're not going to be able to see it. That palate is back in this area here. And their palate's so long that when they say ah, I never see even the bottom of their little hanging down thing, the uvula. And the patient's wife is complaining about how much snoring is going on. So that I know that there's these procedures where they modify that. Tell me a little bit about snore. It's kind of nasal congestion because it's the end of the nose.
Right. So the procedure that you're talking about that most people are asking for and familiar with is called a uvulopharyngeal, palatal pharyngeoplasty, UPPP or UPPP.
Do you get extra money if you can say it?
Yeah, okay. I wish. That's probably the most common surgery performed for sleep apnea, but I caution patients, for one, in my opinion, surgery is in many people's opinion, surgery is most effective for mild to maybe moderate sleep apnea. And the severe people, we're less likely to get them off their CPAP or cured with any procedure.
So the CPAP may work a little bit better. So do they actually cut the back or laser
Correct.
it?
Yeah, and that's the downside. So in order to remove enough of the palate to alleviate the one problem, you end up, if you were to take enough, oftentimes sometimes you can get a second problem where the palate is supposed to close with the back of the throat to prevent food and beverage from coming out
so then the
nose.
food comes through your nose.
Right.
Well, that wouldn't be good.
So, right, correct.
I like CPAP better than food coming through my
Yeah,
nose.
and a lot of people don't tolerate that.
Would that give you a runny nose?
With CPAP?
No, food coming through your nose.
Absolutely,
That's okay.
yeah. A lot of people initially don't like CPAP, and during the consultation, I'm honest with them. I tell them, you know, you have severe sleep apnea. There's not a very good chance I can get you off that with surgery alone. But sometimes a surgery, being a palate surgery or even a nasal surgery for some sort of obstruction, can make it more tolerable for them. We can get their numbers down, but it's very important to let them know that we may not be getting you off CPAP. We're more likely to achieve success being off CPAP with mild sleep apnea.
Do you see much allergy that's so bad that it causes a sleep disturbance, or that like seasonally they can't sleep?
Yeah, well, they do feel it can interfere with the normal sleep cycle, but not necessarily for sleep apnea reasons, but just not allowing you to get that deep, restful sleep. And sometimes the medications you take for the allergies, like the decongestants, can cause insomnia, and then you're tired the next day too.
Well, let's look what we've got for questions. Well, we have a 77-year-old woman from Sioux Falls. The woman has, this is a tough one for us all, has cluster headaches, watery discharge from the nostril from the same side as the headache is. Is this concerning? So do you see a relationship between this whole chronic rhinitis thing and migraine?
That we do. I mean, it's an overlap of symptoms, right? But you know, what she's talking about is a very rare form of headache. You know, usually we say if you hear hoofbeats in South Dakota, you look for horses, not for zebras. That's a zebra, and that would be something you would go see the neurologist for. But we get lots of sort of folks coming in with sinus complaints, and one of the things that's a little bit tricky is you can have somebody with sinus pressure. They have pressure around the eyes and behind the eyes, and they get labeled as sinusitis, but they really have no nasal symptoms. We say, would you come see us for your nose? No. So we have patients who have either migraine headaches, who maybe have episodic full brain involvement, but in between they have more common pressure behind the eyes thing. We have people with...
So you have people who have the pressure.
Right. And
they're not
headaches.
blowing their nose. No, they're not getting green junk out of their nose.
They would not come to see you for your nose, right? And
so they end up getting
well, usually
CAT scans.
for the infections, whether it's viral or bacterial or allergic rhinitis, right, they have like complete obstruction of the nose and the pressure builds up behind. But these patients just have pressure. They would not come see you for their nose, right? So that's kind of a clue. It's a headache, because we have patients who have both, right? And so
you see a lot of patients that you look at and they have migraine or some headache variant.
Absolutely.
Okay, cool. Well, I got one more question and then we're going to wrap it up. My son has coughed in the morning for years upon waking up. Thoughts on the cause? Well, I always ask them, are they coughing anything up? See if anything's collecting in the back. Bob, what do you do with those patients that wake up?
Well, for us, you know, a cold, it doesn't go away, and that would count as one of those. You know, first thing you rule out would be the allergic rhinitis as a cause. But, you know, you can also have this, you know, if they're irritants house, they live in a household where there's smokers or wood-burning stoves or things like that, that can also cause cough. And
very interesting. Very good. Well, any brief thoughts?
I mean, depending on the age of the son, more history. I mean, other things to consider would be chronic postnasal drainage and reflux. You know,
awesome.
When we're supine,
well, reflux,
it could be
very
a problem,
good.
So.
Awesome. Thank you very much. And now, for tonight's winner of the Prairie Doc quiz question, the most common allergy is from cat dander, dust mite, bug dust, tree pollen, grass pollen, weed pollen. The answer is our famous dust mite and the bug dust from that. It was Nancy Marlette of Canton who answered the question correctly. Thank you, Nancy, for participating, and a book will be mailed to you soon. We'll be right back after this.
You still feeling lousy, sweetheart?
Terrible. Day 4 of aches, chills, sweats.
Oh, poor thing. You're just not you when you have the flu.
I don't feel like me at all. Do I look sick?
You look different.
Oh, you're so sweet.
That's not your pretty face.
Feel like yourself. Get vaccinated, because stopping the flu starts with you.
This time of the year, those of us in healthcare hear a recurring bad news nose story. And it goes like this. I've been coming down with it for 2 or 3 days now, and it's a real doozy. It started with a runny nose, aching all over, sore throat, fever, and cough that just won't quit. Where does all that mucus come from? Now it's packed into my sinuses, and I have a headache that won't stop. I usually need an antibiotic to shake this sinus infection. Can you give it to me, doctor? There are a few points about this nosy illness worth repeating. First, our patient is describing a viral illness for which an antibiotic will not help him feel better. At this stage, there is not a bacterial infection. It's going to last a week or two with antibiotics and 7 to 14 days without it. What's more, taking an antibiotic to prevent the cold from turning into a bacterial infection doesn't work and can just make any bacterial infection that might follow resistant to treatment. Use common sense to see your doctor when a respiratory illness is lasting too long, changing, or becoming too severe. Chills and sweats the first day or two is usual, but a return of a fever after 4 or 5 days is a danger signal. The most important preventive is for the infected individual to cover the cough with tissue or sneeze into a tissue or arm if no tissue is available, and then wash your hands after messing with your nose. Unfortunately, vitamin C likely will not protect. And remember, going out in the cold did not bring this on. You got it from someone else. One can generate a tremendous amount of damaging pressure when blowing the nose hard, especially when blocking one nostril, which packs the sinus or ears with mucus. Do not blow the nose except very gently with both nostrils open and only occasionally. Stop the honking. Finally, try to avoid decongestants and cold pills. Instead, a natural or effective way to clear mucus is to stimulate the making of saliva and to increase swallowing, such as sucking on a sugar-free lemon or cough drop, sipping on chicken noodle soup, or drinking hot lemonade with honey. I drop menthol cough drops into a mug of hot tap water for a soothing tea. And if you're suffering, stay home and don't spread the bad news nose.
A heartfelt thank you to Bob Smith, Dr. Bob Smith, and to Dr. Jered Mancell for joining us tonight. I certainly appreciate you coming down. Your insight made tonight's show a great show, Thank you very much. Coming up next week, the South Dakota World Affairs Council has chosen global health as its annual symposium theme. This symposium will be January 28th and 29th in the Volsdorf Ballroom of the Student Union of the South Dakota State University campus in Brookings. The symposium is free and open to the public. For additional information about the speakers and their topics, visit their website. That's SouthDakotaWorldAffairsCouncil.org or call 605-691-2687. This will be a wonderful event with some great knowledgeable presenters. Thank you very much, and I appreciate it. Everybody stay healthy out there.
From the basic cold to the menace of Ebola, chronic pain to arthritis, it is an Ask Anything show next time on Call with the Prairie Doc.
Funding for On Call with Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
Additional funding is provided by
Aberdeen Asthma and Allergy,
Avera Heart Hospital,
Brookings Health System,
Dakota Allergy and Asthma,
Dakota Care,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
South Dakota State Medical Association,
Swiftel Communications,
and Vance Thompson Vision.
Closed captioning for On Call with the Prairie Doc is provided by
Avera,
Brookings Health System,
and Fishback Financial Corporation.